What I'd like to do now is give all of you an opportunity to engage in conversation for this final part of the final session. As people go to the microphone, I would just like to share a couple of impressions I have from today. First, I think all of you would agree that violence is a massive health problem in this country and around the world. It has immense mental health implications, physical health implications. It is largely an acquired, not an inherited genetic disorder, but one that is experienced and can express not only over a lifespan, but have intergenerational transmission. It's also a solvable problem, and I think we've heard that through several panels today. If there's a word that I hope we leave with today, it's before. Before the 911 call, before the ICU, before the need for extended psychiatric care, before a child grows into a troubled adolescent, into an abusive parent, into another statistic. And that we see this as a community opportunity and a societal opportunity, not just an individual one, and one that medicine, nursing, and everyone in health can and will, I hope, play a critical role. Dr. Campbell.
Bridget, thank you very much for that wonderful summary of all that's happened in Kaiser. It's an exemplar that we all need to copy and modify for our own healthcare settings. But I wanted to ask you particularly around the issue of elder abuse, because when we talk about family violence, we oftentimes forget that all too pervasive, all too tragic part of family violence that unfortunately hasn't gotten mentioned. So could you say something about that issue?
Yes, thank you very much. You know, the program in Kaiser Permanente is called the Family Violence Prevention Program. It isn't just intimate partner violence. It's about the whole spectrum of family violence, and child abuse is part of that, and so is elder abuse. We know from some of the research that we're doing internally that much of the elder abuse is actually extended intimate partner violence that is manifesting itself in an older age group. But this is absolutely a critical issue. And it's a complicated issue in the way that child abuse is, because you're working with potentially elders or children who are dependent. So I would say we have not made the kind of strides that we need to make in this issue. But I'm really glad that we've been talking about suicide throughout this day, that we're bringing up the issue of elder abuse, and that child abuse has been part of it as well, in addition to the community violence. So thank you, Jackie, for naming it and making me realize I got to get going.
We only have a few minutes because we have to come in for the closing, so we'll go back and forth here. Yes.
I'm Bob Black. I'm a pediatrician from Monterey, California. And I would like to remind the group that the gang violence is not limited to the big city. It's all over. And indeed, in our area, we're having shootings 2, 3, 4 times a day, and there's very little in the way of prevention. Drive-by shootings are common, and so it's not limited to the poor people who certainly are at risk, but some of the rest of the community is as well. Also, I think that it's important that we recognize that violence at the teenage level is not something that's going to be treated quickly and go away. So often happens they get put in juvenile hall and they reinforce this when they eventually do get out there. They've had a lot of education from their colleagues. The abuse of children is a much more difficult problem, and indeed it's not easily remedied either. Frequently, it's the single mother boyfriend that's the abuser, and sometimes with just shatteringly bad results. And that's not easily remedied, but at least it should be recognized.
Thank you for your comments. Let's go on over to the next microphone. Thank you.
Judy Wasserheit, University of Washington. I really appreciated, as an infectious disease person, I appreciated your framing this as a community violence as a communicable disease. And for those of us who have been working in sexually transmitted infections and HIV for a long time, there's been a concept of core transmitters, which and the use of network analysis, which has been useful both in terms of targeting prevention and care resources, and in terms of thinking about the role of partner services as we frame it. My question to you is, particularly in communities in which there are gang networks, are there ways that that can be translated to interventions to work with gangs, and could you talk a little bit about what's being done and what you think about the efficacy of those approaches?
So, thank you for those comments. I'm actually stealing all of that work and applying those models to this problem with important modifications. Stealing is not the right, arbitrage is what one of my mentors would call it. But the reason I think it's important to do that, and then I'll answer your question, is because it's so super concentrated, and the things that put these young men at risks, the gang question is an interesting question, because that's another binary distinction that's just not binary, is that it is particular behaviors, hanging around people with guns. Guns are durable goods, which is part of the reason it works like exchanging needles. Because in order to be shot by a gun, you have to be near a gun, and you have to be near people who are carrying guns. And like HIV, you don't necessarily have to see that structure for it to affect you. Right? When I bring this back to members of groups and to cops, they call it the cousin rule, which is we're standing on the corner, you're totally innocent, I might not be, you're going downtown, oh, my cousin will give you a ride, and now you're in the car with the cousin. So you don't see that structure, but it affects your life, just like your partner's ex-partners. We're using this, we're actually been applying it to sort of David Kennedy's approach, as well as sort of the cure violence approach in different cities, to try to find strategic point of interventions for the people who are at risk. In Chicago now, we're extending that through public health services there to try to get some of these sort of partner types of violence. So I'll let you know soon. Right, what we're seeing right now is it has a cooling off period, and you know, it's like the lather, rinse, repeat. It's not a long-term solution to community violence, but what it is, it's a better way to do the here and now. So that's the short answer. The gang thing is very complicated, but what this approach lets you do is get past some kind of binary distinction and lets you see the sort of larger structure.
Okay, team, we've got 4 people at the mic and 3 minutes. Do the math. Over here.
Elizabeth Shore from the Center for Study Social Policy. I just want to call attention to a terrific thing that happened in this session. You started it by saying Washington might be an evidence-free zone. A lot of people think that if you want evidence, you have to do a randomized trial. You have had a wonderful example of practice-based evidence that is very rigorous evidence that did not come out of an experiment. And I just want to call attention to the fact that we can get a lot of really good evidence by broadening our view of where the sources of rigorous evidence can come from.
Amen. That was a good example of how to do the last 3. You guys have the mic, one at a time.
Larry Green, a family physician from Denver. The entire day has reminded me of a report that has been recently re-exposed, and a few people in the room will recall, called the Folsom Report. The Folsom Report was done by the American Public Health Association. It was published by Harvard University Press in 1967. The name of the report was Health is a Community Affair. Its core idea was if you wish to have health, you must form communities of solution. The entire day has been begging for the IOM and others to form a community of solution. A community of solution is defined as the group of people who must work together in order to solve the problem. We must get over our sections. We must reunite the triplets separated at birth of primary care, public health, and mental health to solve this problem.
Thank you. Darren.
Wintemute from UC Davis. In implementing the Kaiser program, what arguments did you use to get Kaiser to commit on a sustained basis resources for treatment once referrals were made?
You know, it was not a difficult argument. And that's because we know what the cost is of women who are coming in for intimate partner violence. They're coming in for headaches, for insomnia, for anxiety, for depression, for injuries, etc. The cost is already there. What this does is allow us to have a more effective intervention. So it's been interesting that this doesn't require a new building, a new technology, a new personnel, a new medication. So that when you look at where the opportunities are and you frame the sort of position that way, it hasn't been a problem.
Final question.
Harry Hyman from Stature Health Leadership Institute at Morehouse School of Medicine. I had the opportunity to finish a year as a Robert Wood Johnson Health Policy Fellow. So I was on the Hill this past year. And an amazing thing happened when SGR was being discussed. There were thousands of physicians storming the Hill. When gun violence and mental health was being discussed, I had a challenge finding colleagues on the Hill. I think sometimes we fall back into our medical models and we fall back into our role as the finders of knowledge and fact, and don't forget that we have a responsibility to translate those facts into evidence-based policies. And I think gun violence is an area where we know enough to do more, but we don't have the will to do more. So I challenge all of you. I know one of our experts today commented that he reached out to his legislators, not once but many times. I think we know a lot. I think we don't do a lot. And I challenge you to move out of the medical silos and the medical office into the communities and into the policy zone and realize that that's where we have the opportunity to have the greatest impact at advancing health.
Thank you. I'm going to take this opportunity in my new role to quote an American general as a way of wrapping the entire day up. Russ Honoré, who many of you will remember led American military into New Orleans at the height of the debacle that was Katrina, had a way of cutting through the nonsense when he was talking to the media and others. And Russ's remarks would do well for us to remember today and our colleagues in D.C. and around the country, and that was, don't get stuck on stupid. I think when it comes to violence, we've been stuck on stupid for 50 years, while the epidemic of has waxed, mercifully waned, but now may be waxing again. You've heard today in every panel, from the first to the last, we have tools, we have techniques, we have methods, we have strategies that work. We do not have to live in a violent society in the United States or worldwide. Science and health can make a difference. Let's get out there and do it. Thank you.